There we go. Okay, so can you see the share screen, everybody?
Yeah.
Did anyone have an opportunity to watch the video yet with Dr. Vicky?
Yeah.
And so she apologises for the poor quality. We will redo that, but her internet was not happy bunny, was not playing.
I think we didn't miss much though from their poor internet, did we?
Yeah, she's still great, but we'll try and record that again because you guys, all of this content is being put onto a platform that you guys will be able to access for however long.
I didn't watch it yet.
Yeah, so you'll be able to see all the videos again, still, have all the resources linked there. So when that happens, we'll re-record the interview with her in her office and then pop it up there. So it'll be a nicer copy. But yeah, she's always great. Well, who's that? Someone else joining us. Hi, how you doing? It's Sally. All good. On mute, but waving at us. All fine. Okay, so learning objectives for today. We're going to look a bit at colic and reflux. Big issues for many babies. Going to look a little bit at jaundice, although we did cover that in Lisa Marie, the midwife's video as well. So between those two, normal newborns and illness, it's jaundice. It can be both normal and an illness. And we're going to look at the danger signs of infection in an infant. And again, most of that was covered in Dr. Vicky's talk, but because it's so important, we're just going to recover it here. And then again, just look at very briefly at common infant illnesses, but predominantly today we're looking at the colic, the reflux, the allergies, because Dr. Vicky obviously is much the better person than me, being a paediatrician, to be speaking authoritatively about children's illness. So that's why her video is so important. Okay, so we'll just start off with an activity, and we're actually going to do this activity again at the end of the session. So it means that we're going to look at what we know now and then reevaluate at the end of the session what we know then. So what symptoms would we associate with a baby has colic, a baby has reflux? Could it be both, or it could be something else? So if a baby was crying, what would that just initially make you think you might be considering, colic or reflux or something else, or both of those?
Colic.
I think colic.
Yeah, so if think about colic, we often think about crying to do with colic. If a baby was windy, what might we be just tipping at the back of our heads and thinking?
Colic.
Yes,
colic.
Okay, there as well. Bringing their knees up to their chest.
A colic.
Colic.
Colic, okay. Spitting up milk.
Reflux.
Okay. Constipation.
Reflux. Or something else.
Something else, maybe.
Reflux and something else.
I'd say something else.
Right,
Or reflux, that's fine.
I can probably copy that and have two boxes. If I just put insert another box here, we can have it again, because people say different things, and at the end we'll go back and see what we think then. There we go. Red rashes around the mouth.
Something else.
Something.
Yeah, something else. Any ideas on that one? What you might just be worrying about?
Thrush, yes.
Okay. Arching their back.
Colic.
Colic.
Okay. Hiccups.
Something else.
Okay. Baby not wanting to be put down.
Colic.
Colic.
I would
I
say
think both.
Or both.
Both, yeah.
I'm hearing a lot of boths. Okie dokie. Diarrhea.
something else.
Something else.
Okay. And vomiting.
Reflux.
Okay, so over the course of the session today, we're going to look at those symptoms and what they might mean for babies, and then we'll review at the end to see would we change any of these positions.
Okay.
So first of all, we're going to look at colic. So we used to have what was called Wessel's rule of 3 for colic. We said a baby was colicky if they were crying for 3 hours or more a day, 3 days or more a week, over 3 weeks or more. And that's kind of defined as colic. And traditionally, we say a baby's colicky when they are crying inconsolably. All babies cry, but that kind of crying where whatever you're doing, you're really not able to comfort them. and if you've got them, you're doing all your tips and techniques, but they're still a very unhappy baby. Often we see that behaviour in the evenings more than during the day. Parents might call it the witching hour, or other names like that, to say that there's something that seems to hit their baby, and their baby's generally fine for the rest of the day. This evening period is super difficult. The newest definition for colic, the clinical definition, is spasmodic contraction of the smooth muscle of the intestine, causing pain and discomfort. So look at that new definition and tell me what that means people think it might be related to. If we're looking at the spasmodic contraction of the intestine, what do we think it might be related to?
The knees coming up.
Yeah. So if your knees are coming up, it's because your tummy's really...
And wind.
Wind.
So again, something inside the stomach being painful.
Painful, yeah.
I'm just going to
Vomiting.
All of them.
Yeah.
So it's telling us that there's probably something to do with what's happening inside the baby's tummy. And often with a colicky baby, you will find that they are very... got a very hard tummy, that it actually feels like their tummy is hard.
Windy, but it's windy.
Yeah, which can be the wind inside.
Yeah.
So that high-pitched, inconsolable crying. Be aware, a really high-pitched cry that is unusual in a baby should be a meningitis flag for you. So if that baby's got that super high-pitched cry and they seem very inconsolable, the first thing you're going to do is a meningitis check. So you're going to, check their temperature, check for any rashes, keeping a very close eye on that baby. What we're talking about here is that really high and upset crying, but for, a few hours, most evenings, most week, so a lot of the time, rather than it being a one-off behaviour. But do always have that meningitis flag in the back of your mind. Colic is not an illness. Colic is not a disease. Colic is the name we give to some of these symptoms, most often that crying and the things that are related to the reasons for the crying, but it isn't a disease. So if you go to a doctor and you describe this baby's behaviour and they say, oh, it's colic, that's not the same as you going to a doctor and them saying, oh, you've got irritable bowel syndrome, or you've got epilepsy, or you've got something that is a medical diagnosis. It's simply a lay word to describe all of these symptoms at once, which we tend to ascribe to small babies. So it can be quite normal behaviours. It can be overstimulation. One of the theories around why babies cry a lot like this in the evenings is that they've just had too much going on that day and they're processing. Other theories are around intolerances or allergies. And some babies will behave in this way and then actually later on turn out to have an allergy, such as CMPA is cow's milk protein allergy. Oh, now that's very strange. Sally Ann came back on 2 computers at once. I mean, we love you. We had you twice. That's great. Very confused. Oh, you're on mute, Sally Ann, so I can't hear you.
That's why I was late, so I'm sorted now.
All good. Absolutely fine, no worries. We just had 2 of you, which is fantastic.
Because I was on my phone, sorry.
Right, so it might be CMPA. It might be that gut microbiota, so something in their stomachs that they're not very happy with. And we know that when we're particularly putting formula milk into a baby's tummy, it's not what their tummy was expecting. But it isn't a disease. So there isn't one medicine that treats it. So if you're epileptic, there'll be a range of medicines that the doctor will work through to treat it. It's not like that. We do know, though, it's more common when mums smoke, which says there's something maybe environmental about that reaction. It's more common in formula-fed babies. Again, we know we're putting something into the infant's stomach that they're not expecting. And in most babies, it resolves by 3 to 5 months. So mums are often told, oh, that'll peak and go about 12 weeks. And it's really important to bear in mind that although many of the colic behaviours can be quite normal, there can be underlying reasons for it, such as allergies. So it's important not to just say, oh, your baby behaves like that. All babies do this. This is normal. Don't worry. It's important to reassure that many babies do this and it can be very normal, but also to be on the watch out for other symptoms to make sure you're not missing a trick in terms of infant allergy. Okay? So how do we help with this colic? Because we're not doctors, and this is not a diagnosis. It's just when we see these symptoms, what do we do? So we look for things that it might be. So we're looking for a baby who's had a lot going on. Has this baby been passed around all of the family all day and is finding that difficult? Or is the baby not having enough going on? Is the baby just being left in its crib most of the time? Is this a mum who is, you know, sleep training very early and they're just popping the baby down every 3 hours and expecting them just to be there for an hour? So is it actually having not enough stimulation? Are the obvious things ticked off? Is this little one hungry? Or have they had too much in their tummy and they're feeling overfull? Is their position uncomfortable? Have they got gas? So have they got wind? Birth trauma can be an issue in terms of if a baby has come out in a funny position, maybe having Ventouse or forceps or a cesarean, they can have issues around their neck or their muscles, which will ache. And just like if you guys had been on, a long run and, next day or the next few days you'd ache afterwards, the baby may have these aches and pains from a traumatic birth. They could have an infection, so we're always going to keep those red flags, which we'll go over later, for infant illness in the back of our mind. Or they could have an allergy, which is making these behaviours. So we feed on early cues. We don't wait for 4 hours because that's what someone's book says. We're looking to see what are the cues these babies showing us. So remind us, what are the early feeding cues that we will be looking for with this baby? Anyone? Early feeding cues?
I like eating his hands. The baby's eating his hand.
Yeah.
Opening and closing their mouth.
Or Alicia, I think you're speaking, but I can't hear you very well. It's either
Opening and closing their mouth.
yeah, and turning to one side.
Crying.
Yeah, crying is a late feeding cue. Rooting.
Hard tummy.
So hard tummy wouldn't be a feeding cue, but it'll be a case of maybe we're going to look at some winding there.
Oh, okay.
Yeah, rooting. The baby might be rooting. So we're going to look and see if they want to be fed again. We're going to use, if they're a formula fed baby, paced feeding, which you all demonstrated perfectly. If they're a breastfed baby, we might try for an upright feeding position, like a laid back feeding position where the baby's down the body, so that they're able to be more upright if there is a wind issue during the evening. We're going to make sure that they're winded fully. So how might we put babies to wind? Let's get some different ideas for winding. I've shown you one, but what are the others?
So sitting sideways across your lap.
Yeah, let me grab a baby, hang on. One baby grabbed. So sitting across my lap like this, we can hold under here.
Yeah.
Or cross like this.
Yep, crossing the right shoulder. Always the right shoulder, and I don't know, my camera may be
Oh yeah, mine is the right.
sometimes. It's always the right shoulder. The right shoulder is right. And that's because if you remember that the gut is here and the tube is now going upwards. So what, 2 winding positions?
Yeah.
Anyone like to offer a bit of a tiger in the tree? So that is, how can I make my camera better? There we go. So we might pop baby over an arm.
Yeah.
Like here. This is a really, really good position for babies because they feel very supported. They've got pressure on their stomach, which helps if they're feeling uncomfortable. Often a baby who's very unsettled like this will calm like this. And there is a doctor in the US who does a great demonstration online where he does the flying baby. So he's got his baby over his arm here and he's flying it up like this. And this is, again, a super calming thing for a baby. Dads often like to do this a lot. Tiger in the tree, I find, is quite a dad position. Try and wind. Anything else for winding? Any great tips from anyone?
Caroline,
Yeah.
how about if you put baby on one of your thigh and support the tummy on the other thigh? I've seen
Ooh.
that before.
I have not seen that one. Let me try it out. Okay, so sorry, I had your photo down my boob there. So I'm putting it
Okay.
on one thigh.
So
Yeah, like that.
no. Sit like sitting, but put that thigh down. Yeah, and then the baby can be supported by the other thigh.
Oh, do you mean look? What should foot the other
No,
way?
no. No. On there like that, but her legs will be in between your thighs. But the thigh that the baby's sitting will be down, like lower than the.
Ah,
So like that.
like
Yeah,
sorry,
yeah.
I've just
Yeah.
tweaked. This is a new one on
exactly
me,
like
so
that.
thank you. I'm liking this new teaching. So we've got baby
Yeah,
like
That
this.
one.
Yeah?
Yeah.
Mhm.
Yeah. It helps.
Nice one.
Yeah.
Anyone a fan of Round the World?
Yeah.
I've seen that. Yeah.
Yeah. Or
Yeah,
anyone a
I do
fan?
that.
Yeah.
Putting your
Exciting.
feet up.
Bicycle, yes.
And I did this and I
Bicycle
demonstrated
exercise.
once. Schoolgirl error. The baby did not have a nappy on at this time. What happened? I was cleaning poop off that wall, let alone off me.
Oh.
Very effective. There we go. Oh, there we go. So we are going to try winding and say, although this is a really good position, this is my go-to magic winding because we're helping and using the position of the esophagus. If this isn't working, we'll go through our different options and we'll find with our baby, which we're working with, which one works really well for them. So that's my go-to, but there are all these other options, including a new one. Thank you from Sally Ann today. With your permission, I'm going to add to my repertoire. Credit to you.
Hopefully helps.
So we're going to wind. Going to baby wear. If this baby's really colically and uncomfortable, we're going to have them in a sling, maybe try them in a sling, so see if they're going to calm by just being on us all of the time. A colicky baby is not going to calm by putting them down in the crib, trying them down in a crib. We're just going to have a tearful baby and probably a tearful mummy. So you can try baby wearing them around. Might try some simple infant massage, warm bath, rocking and holding. So we're going to do all of that 4th trimester stuff to try and help this little baby to calm. But particularly with colic, your role as a maternity nurse or a night nanny is going to be around supporting those parents. So listening to them, validating their feelings that parenting a baby that is colicky is rough. It is not what you are expecting. It's not what you were imagining when you were planning for having a baby. So listening to them, validating that it is okay to feel upset, and giving them measures to help them feel calm, which may, if it's when you're not on duty, may involve sometimes walking away for a minute and then coming back. And we know that the danger of shaking babies is real. I don't know how many of you are old enough to remember the case of Louise, who was a nanny 15 years ago, something like that. Young nanny, worked in the
Yeah.
school.
No, it was longer than that. It was.
Was it?
Yeah, it was about.
Oh,
20.
don't make me feel even older. It's my birthday.
Yeah,
Yeah.
my
Come
my
on.
plan was to qualify and go to America, and that stopped me.
Really?
And I've been
Go on, tell me how many years ago it was.
I qualified 22 years ago, so it was about that long ago.
Oh. Right, so for those young ones, unlike Alethea and I, who don't remember this, it was a nanny and she was quite young. She was looking after a baby and the baby died. And the investigation showed that she got so angry, she'd shaken the baby. Baby's little skull in there is their brain is incredibly delicate in there, and the movement, even a small movement back and forth, is enough to seriously damage the brain. So shaken baby syndrome is something that we really always want to guard against. There is a particular link with male parents and shaken babies. There's actually some new safeguarding videos doing the rounds on the internet, the ICON resources. And it's about calming yourself and sometimes walking away. So we know we say don't leave babies to sleep on their own, cot death, yada yada. And that's always true. But sometimes parents need to be told it's okay if your baby's really upset, but you need time to walk away just for a few minutes and then come back to your baby. if that is what is going to keep your baby safe. And particularly male parents who can't breastfeed. Because, you know, boobs are a great old colic comfort. So if you've got dads, they may be having less of the baby care, as you know, because that's a cultural thing for us. So they may have less of those skills already in place because they're not caring for their baby perhaps as much in terms of hours of the day as the mum has. So reassuring them that they're not doing anything wrong, and sometimes if they need to walk away and come back, that is the safest thing for the baby. That's what they should do. So a lot of colic support is around emotional support for those parents. Okay. Lots of people will say, right, colic, oh yes, your baby's got colic, they should have. Give me a list of things that you've heard medication-wise for colic.
Right water.
Right water. Oh, right, gripe water. It's probably the lowest on this list of things, well, the highest of things I hate, okay, in terms of gripe water used to work with, we used to put alcohol in it. So that's where gripe water's coming from. We used to dose our babies with a little bit of alcohol, and amazingly, they went a bit quiet after that. Gripe water nowadays does not contain alcohol. But also it doesn't contain enough of anything to actually do anything. It is purely placebo effect. So people who swear by gripe water are swearing by placebo effect, which is fine if that works for them. But as a maternity nurse, you should not be saying this is something I recommend, because it's not an evidence-based treatment. And if you look on the NHS website for colic, and I'll bring it up, seeing as we have the power of the internet, I will bring it up for you. We'll say that the NHS are not recommending it. So parents are at liberty to buy it, and it's not going to do their baby any harm, but it's also not going to do their baby any good. So what we want to look at is actually the underlying reasons for the colic and other measures to support. So let's just stop that share and share up the NHS, because this is our go-to. If parents saying, should I do this? If you're unsure, let's go back to the NHS and say, is this what your midwife would be saying? So you may hear about anti-colic drops, herbal and probiotic supplements. Changes to diet and cranial osteopathy. And it says there's very little evidence that these things work. In fact, there's no evidence for gripe water particularly. So these are things that we're not going to be recommending to parents, because we're going to work in an evidence-based way. Okay, right, stop that share, back to our screen. There we go, share. Okay, so what else do you see on the shops to help by colic, for helping colic, or parents swear by?
Infocol. Oh yeah, Infocol.
Yeah, Infocol. Infocol can do something, and it may be the right thing for the baby, or it may not. But it's definitely not a cure-all for colic, because as we found out, colic is not one illness. It's a name for a collection of symptoms which have different reasons. So Infocol, it works on any bubbles that are in the stomach, bubbles of air that have been taken in when feeding. And it helps to form little bubbles into one bubble, and the one bubble can then come out with winding. So if the problem is that there are lots of little bubbles in the stomach, Infocol is able to help. Yep.
Yeah.
But you don't know that that is the problem. So it's not colic, so Infocol is the cure. If the problem has been bubbles going in, it will help. If bubbles of air are getting into the stomach, what will help more?
Is it the breaks between feeds?
Let's think about preventing. Let's check that baby's latch onto the bottle or the breast. Where is that air getting in? Is it because baby's being fed too late and they were crying? So crying with that late feeding cue. Parents or you have then fed the baby, but because they were quite cheerful at that point, they're still taking in air.
Mm-hmm.
So we're going to say, yes, if there are bubbles of air in the stomach, that Infocol may help. And if it helps, we're going to go backwards and go, right, what's the prevention for this? How can we get rid of the air whilst feeding? Is it that when parents are feeding, they're not filling that teat if they're formula feeding full of milk? They've misunderstood you with paced feeding, and they've got it completely horizontal, and the baby's taking in a teat with half milk and half air.
Oh.
So let's look backwards to see, what are the reasons for this. So we've got Infocol. Any other things that are on the market for colic?
Mm.
Anyone heard of Coleaf?
No.
Yeah.
It's not as
I've heard of
well known,
Coleaf.
but it's still on the market at Boots, that sort of thing. And that Coleaf, yeah, it uses lactase, and we'll learn about lactase later when we're looking at lactose overload. Lactose is present in all milk, breast milk and cow's milk, and lactase is the enzyme that breaks down the lactose. All babies will produce lactase. If, however, baby is having, and we'll look at the reasons why, a little bit of lactose overload, they're having too much of that, and they're not producing enough lactase themselves, then Coleaf might well help. But it won't help if there are bubbles in the stomach. And it won't help if there is a different allergy going on. And it won't help if baby's overstimulated. The only time Coleaf would help is if there is a lactose overload going on that we need to balance out with some more lactase. So for those type of medicines, they can be effective, but for a small quantity of babies. So it's important not just to go to them as I always use this. You've got to look at that colicky baby, go through those symptoms and try and work out what might be happening to understand which, if any, medication might be useful. But the gripe water, it's not just there's no evidence, the amount of active ingredient in it is so tiny. It claims to warm the stomach and change the stomach pH, and it's got 0.05 active ingredient, and you're giving a couple of drops. There literally isn't enough science in there to make any difference. So that's just a triumph of marketing. What they all do is they all contain sugar or sugar substitutes. What do we know about pain and sugar? Anyone seen babies who are having injections being suggested to breastfeed, or to babies who have had injections for other reasons, maybe in hospital, being given a small amount of glucose in their mouths? Sugar.
Pain.
Yeah.
Does it soothe? Yeah, it soothes the pain.
Yeah, sugar soothes pain. So which is why I recommend all of you, when you're feeling down, have a big bar of chocolate, because it can make us feel better. Sugar is good for some things. Maybe I have a little too much.
And then half an hour later, you're like, damn it.
Yeah, but yeah, that sugar, that glucose does have an impact on pain, which is why in hospitals for tiny babies having procedures, the midwives or the nurses will actually be giving or offering them, the parents have glucose just rubbed in the cheek of their mouth to help them with that pain relief. So if this little baby's in pain and I give it a medicine that has sugar in it, there is going to be a pain relieving element. It's really important to understand that, and the placebo effect is really important to understand that, so that you're not just going out there going, this is what works for colic. Understanding what the medicines actually do or don't do will help you to help parents to make the right decisions. What I see so much of that though on maternity nurse forums is, oh, what should I do with this baby? Give them X. X always works for me. And what we're not then doing is looking at the baby and what the underlying reasons are. Osteopathy, cranial osteopathy, which is the small this is not real cranial osteopathy, but having a baby and manipulating the skull. Clearly they, I don't know, but something like that. No evidence base for that. General osteopathy, pediatric osteopathy, there is an evidence base for it. It's small, and if babies had birth trauma, they can have what's called torticollis, which is tension around here. So osteopathy, it's not a big evidence base. It might be worth a suggestion. Cranial osteopathy, no evidence base. Chiropractic treatment, again, very little evidence base. It's a weighing up, to see what the parents are thinking. Sometimes IBCLCs, lactation consultants, will suggest going to osteopaths when there is a specific tightening they can feel around the jaw. But that's not saying it's a cure for colic. It's saying that actually there's some benefit in osteopathy for releasing some muscle tension from the birth process.
Would you say that's the same for the physio as well?
No, there are clear evidence bases for physio. clear. And there is evidence basis for chiropractor and osteopathy for certain things.
But not for colic.
Not-
I see what you
See,
mean.
there's the difference. So
But
osteopathy,
physio's not got evidence for colic, or it does.
no,
Okay.
no, you wouldn't see a physio for
Yeah.
colic, no. But so it's important to work out what does what.
Yeah.
Osteopathy could be effective if there is a tension or trauma here from a difficult birth. Say this baby was a forceps baby. Yep. Has anyone ever seen forceps births?
No, my cousin had
No.
one, but I didn't see it.
Okay, I've been with my birth doula hat. I've been at a forceps birth where, no word of a lie, the registrar was pulling like this. She was down lower and heaving to get that baby out. Unsurprisingly,
Both my
baby had some issues with feeding because it had 2 large bits of metal clamped there to pull it out. And I'm not saying that was the wrong clinical decision. That that was what that baby needed to come out. But there are consequences of that. So osteopathy can help if there's tension around there, which could cause the crying, which we've called colic. But it's not a treatment for colic. Again, it's looking at underneath. Probiotics. There is no good evidence base to give probiotics directly to babies unless your GP is recommending otherwise. Probiotics are basically bacteria. And as adults, our stomachs are much more able to cope with a range of bacteria. Babies, tiny stomachs. We are not doing anything on the microbiome in this course, which is a real shame because I just didn't have enough time. But the microbiome is, it's brilliant. We can do a whole course on this. But fundamentally, it's looking at the lining of the gut and of the baby and how the birth process and the first processes in life of feeding and being next to skin help to give the baby the right kind of bacterial mix to survive in life. And so we know that probiotics, which are bacteria, are going to have an impact on their gut, but we don't know what the impact's going to be. So with a probiotic, you're giving bacteria into a tiny baby with not being very sure about the impact. So that is quite an uncomfortable thing to be doing. Your GP may recommend it if the baby's had antibiotics. So they might be making a decision based on the baby's health to try and replace some of the bacteria that have been lost because of the antibiotics. But it's not something you as maternity nurses should be recommending for a baby. You should not be recommending putting bacteria into this baby, okay? If it's a breastfeeding mum, she may choose to take a broad spectrum probiotic. And as an adult, her body is much more able to cope with any ill effects of this. It's still very new technology, probiotics. We don't really know a lot of what it does. So it may be in 5 years, in 10 years, we're giving different advice. But at the moment, steer clear for babies unless it's under GP. Comfort milks. Comfort milks claim to be milks where the proteins are slightly broken down. There is no evidence for these. The First Steps Nutrition website that we looked at in our second infant feeding discussion has a great section on what the value is of the different milks. And comfort milks, it's really clear there is no benefit per se for these milks. If the baby has a mild cow's milk protein allergy and they're formula fed, it may help. However, if a baby has a mild allergy, they shouldn't just be being given different milk by their maternity nurse. They should be seeing a GP. Yeah. So we're not just going to go, your baby has colic, let's try comfort milk. Right. Before we move on to reflux, any colicky questions?
Oh, I've got a question. So we learned about pairs feeding.
Yep.
So I just heard you say that sometimes you leave half air and half milk in the
That
nipple
parents
of the
might,
vessel.
and that would be a bad thing, yes.
Okay, so we don't. Okay, when we do it horizontally, doesn't that just make it half?
No. So when we're doing paste feeding,
Mhm.
Where's my camera? So I'm looking at you. I'm putting it to you, and you're not my camera.
Yeah.
There's my camera. Okay. If we're just over horizontal, the liquid
Okay.
you're going to fill up this whole teat. So everything that's in
All
the
right.
fingers must be filled. This doesn't
Okay,
need to
I
be
get it.
full, but this does.
Ah, that's where my confusion. Okay,
This
yes,
is
I
all
get
full
it.
of milk. The bit that I'm just twisting here, only milk's going into the baby. What parents might do if they've misunderstood is have it completely horizontal.
Yes.
There's enough milk in the bottle. Where my finger is, half of that
There
is going to be
isn't.
milk and the top half air.
Yeah.
So if the baby's then sucking that, we've got a lot of air going in.
Yeah.
So we're having a happy medium between air in the teat, dripping, and you've got to drink it because there's no other choice.
Yes.
So we're reducing the flow here, but still keeping that teat always full of milk.
Okay, good.
Yep.
I understood.
No worries.
Understand.
Any other colicky questions?
Thank you.
Okay, we'll move on to reflux. We can always come back to some more questions later. Reflux. Reflux is mostly normal. Okay, really want to reiterate that. Reflux is mostly normal. Reflux simply means bringing milk or anything else back from the stomach up the esophageal tube. That is what reflux is. Reflux is not an illness. It's just the bringing of milk up. Most of the time in babies, the milk comes all the way out. And we have different names for that. You might call it vomiting, you might call it posseting, you might call it bringing milk up. And that's pretty jolly normal. And some babies will bring up more milk than others. Some babies will do it most feeds. Some babies will do it occasionally. Baby I lived with for a year, not my baby, my housemate's baby, it looked like she brought up every feed for an entire year. She was massive. She was growing. So something I do with parents to reassure them when their baby is posseting or bringing milk up is I fill 1 tablespoon with milk and I put it over a baby grow. Boy, did that baby grow get wet. So one thing to really reassure parents, if you have no other worries about the reflux, is by reassuring them that most milk is still staying in the stomach and actually what comes out is a small amount. Did any of you guys do an experiment when you were in high school, when girls are often worried about how much they're bleeding when their periods start? Yeah, and actually it's around a teaspoon of blood or something really tiny, but it looks like you're going to die. Imagine that experience and put it onto mums with a refluxy baby. It looks like their entire feed has just come out and their breastfeeding has been useless. That is almost certainly not the case. It's just that milk spreads very quickly. So do that experiment if you've got a really refluxy baby. We have a lot of refluxy babies now because guess what we've started to do a lot of the time? We feed the baby and we let them down on their back. Who loves to have a lovely big meal and go straight to sleep on their back? Not many people, and particularly with babies. You know that tube I keep talking about, the one that when we have them like this allows the air to come up? It's got a little flappy bit, and the little flappy bit, the valve, is generally what should keep things down or let things back up again. And in babies, that little flappy bit, the esophageal sphincter, if we want to be technical, is often not very well developed. It's just a little bit immature. So for us to be sick, our stomach has to do quite a lot of work. For babies, not so much. That little esophageal sphincter opens and closes very easily, allowing things back up again. And there's probably nothing wrong with that. It's a way if babies tick something in, and you remember cave babies that didn't suit their stomach, it would just come straight back up again so they wouldn't get poisoned. It kept them safe. So that being not very well developed, combined with our tendency in the West to put our babies down like this a lot, means a lot of the time milk will come straight back up again. That's what we would call positional reflux, that the baby tends to puke because we're putting them on their back and the milk isn't staying down. Completely normal, nothing to worry about. If the baby's doing that a lot and there are no other symptoms and baby does not seem disturbed by it, not be referring on to a doctor, we'd just be going, yep, babies do this.
Yeah, just a question. Is it advised to put a pillow under the baby when he's sleeping?
It used to be advised and now it is not advised.
Because my sister was advised so by his healthy visitor.
it used to be the case that we would put pillows underneath the mattress,
Yeah.
and then the science has balanced reflux and SIDS risks and decided
Okay.
that the most important safety is a flat mattress.
Okay.
So that used to be the case. And because, of course, it used to be the case, there will always still be health professionals who haven't kept up with their training who will still be advising it. So your sister may have come across someone who's a bit old school.
All right.
But the newest guidance is no, we keep them on a flat mattress.
Okay.
If the reflux is so severe that they've been going to the doctors with it, the GP may then advise to tilt the cot slightly,
Yeah.
about 30 degrees. We would not do that by putting a pillow under the mattress. We would do it by either buying a cot where it has sides that you can change, so that the manufacturers have made it so that you can tilt.
Yeah.
A little like the cots in hospital are made to do that. Or if not, we would raise an entire end of a cot up, for example, on some big encyclopedias. We would never raise something under the mattress though.
Okay.
The only time you're going to tilt that cot is when a GP has told you to do so. And if the GP's told you to do so and something happens, who's to blame?
You.
It's the GP's said. The GP's advice is to do that. The GP has taken the responsibility for that advice. Yeah. So if
You don't have to get that in writing or anything.
frankly, I would.
You would.
I would make sure it is on the baby's notes.
Okay.
If the GP is advising something that is off guidelines, I would always ask for it to be written down as protection for everybody.
Okay.
But general advice used to be to tilt the cot, and over a recent couple of years that has changed, which means there will still be many health professionals who haven't kept that updated. Silent reflux is the name we give to when milk comes up the tube but does not come out of the mouth. So it comes up and then goes down again. Who can think of an adult name for something like that we might suffer from?
Oh.
The heartburn?
Sometimes it presents as heartburn in adults. So yeah, so silent reflux is coming up and going down again. If a baby has silent reflux and there are no other symptoms, you may well not know about it because they're pretty happy. They're happy babies. But when you get lots of symptoms but there's not milk coming out, you're going to think about silent reflux and treat it as if it is, because all of the treatments we're going to give are not medical, they're just supporting the baby's feeding. So it's something to bear in mind. If a baby's super uncomfortable, but there's still not milk coming out, don't dismiss that milk might be not coming up here. It could be making this baby super uncomfortable. Reflux usually begins before about 8 weeks old, when we have babies on their backs a lot. Usually declines after 6 months. What do babies do about 6 months?
Sit up.
And so what's the change when they reach 6 months, generally?
They
What's helping?
can digest.
Yeah. Yes, you've not, as soon as they're sitting up more, they're not doing that more, so the positional element goes. So often reflux will disappear or lessen because the baby is simply spending more of their time upright. If you've got a refluxy baby and they spend their time like this, good thing, bad thing?
Good thing.
Yeah, because the baby is not lying down, so their esophageal sphincter is not having to do much work. We're helping with gravity keep that milk down. So refluxy baby, let's try them in a sling. But it's very normal, and we say about 40% of babies bring back at least one feed a day. That doesn't mean the whole feed, it means a part of it. And 5% of babies will do that 6 times or more a day, and it still not be a problem. It's just babies being babies combined with us putting them down more. But reflux can also be uncomfortable for babies and cause problems. So they may cry, they may be irritable. Hiccups can be a sign of reflux. It's not always, because who had hiccupy babies inside them? Who's here's had a pregnancy with a baby where they felt hiccups? No? Okay.
No.
Some babies do inside, some babies don't. If they did, would it be reflux? No, because they're not digesting anything. So some babies are just hiccupy babies. So a question to ask mum is, did this used to happen before baby came out? And if she says, yes, this little one inside was hiccuping every night, right, it was really irritating, then you're going to less link it to the reflux, aren't you? Because you've got some knowledge there that baby had an inbuilt predisposition to be a hiccupy baby. If mum says, though, like Maria's just said, no, my babies didn't do that inside, then you're going to think, okay, maybe the hiccups are a new thing. Maybe they're relating to something with the digestion. So you're using that birth history and that pregnancy history to help you decide what's the normal for this baby. Coughing can be a symptom of reflux. And then we're going to go on the next page to some more symptoms which are more worrying. But when it's the normal physiological reflux or positional reflux, we're giving that support for the parents. We're acknowledging that it is difficult. It's embarrassing to have to go out and every time your baby, oh, shall I hold the baby? And you're thinking, no, because it's going to puke on you. That is difficult. It's difficult to go out and think, shall I go to Tesco's with the baby? God, how many changes of outfits do I need to bring? So it can be really tough for parents. So don't sort of negate that aspect of your support. But generally, and the NICE guidance, which is, NICE is the National Institute for Clinical Excellence. It's who writes the guidance for doctors. The NICE guidance is that reflux that doesn't bother the baby with no additional symptoms does not need to be investigated medically. It's just sort of a normal part of infancy, and we'll manage it through paced feeding, so frequent feeding, small amounts, and positioning. And reassurance. So that's what NICE says. But say there can be some other issues going on. Doobie-doobie-doo. Oh, hang on, that's not the... I've got 2 slides that say almost the same thing. Hang on, what do I want? Right, what we want to look at is the second 2 paragraphs here. Sorry, I've realised I've got the same thing twice in the first. So, can be trapped gas. Feeding that baby too much. If milk's coming out, you're going to think, did the baby have too much milk? What's the likely thing that's been happening if a formula-fed baby is bringing milk up because their stomach's overfull? What's mum or what's the maternity nurse been doing? Formula-fed baby, bringing lots of milk up. What could you think about?
Overfeeding.
Yeah, you're going to look at portion sizing, aren't you? You're going to weigh that baby, look at the graphs and say, how much milk should this baby be getting? Are they getting A, the right amount over 24 hours? And B, are they getting small frequent feeds, or is it once every 4 hours and then that is just too much for this little tummy? So that's one of the first things you're going to look at. Position, we've talked about, could be an upset tummy. Fully breastfed babies are very, very unlikely to get gastroenteritis or upset tummies. Formula-fed babies more so. Why would that be? Why are formula-fed babies more at risk of gastroenteritis?
The bacteria being introduced to their stomach.
Yeah, there's more opportunities with making up a formula feed to have bad bacteria in. You might have not made up the feed with hot enough water. Might have made up the feed and left it too long, so they might have not sterilised and washed the bottles properly. All of those things are points where bacteria can enter baby's system, which is why, one of the reasons why formula-fed babies are more at risk of gastroenteritis than breastfed babies, because there are all those points where things could go wrong. Your job as a maternity nurse is, when it's your shift, to make sure that those things never happen by scrupulous hygiene and appropriate feeding of that baby. It could also be something to do with the milk it's having, a reaction, an allergy or an intolerance, and we're going to cover those later this session. But it can be something more serious. Reflux can actually, when it's with different symptoms, be termed gastroesophageal reflux disease, or GORD. Gastroesophageal means this bit here in the baby. So if a baby is bringing up milk and it has 2 or more of the following symptoms, we're going to be going down to the GP. So not gaining weight. If they're bringing up milk and they're not gaining weight, something is going on. It's not good. We need to get that baby checked. Frequent and forceful vomiting. When a baby posits and it's just normal reflux, the milk does that, just goes straight out. If a baby is projectiling it, and you can hit the other side of the room, that is not in the scale of normal, and it's going to be something we want checked out. Sometimes the GP will go, no, this is normal for your baby, but we're not going to take that as a baseline of normal. If there's forceful projectile vomiting, we're going to say, yeah, there might be something else wrong, we want to get it checked. Distressed behaviour. If it's this colicky baby who's then bringing up milk, then cry, 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 blur, that's a signal that there's something wrong there. If they've got frequent coughs, hoarseness or pneumonia, that's another sign that there is a reason for this reflux. So babies who are more at risk include, and we know preterm babies, babies who had hernias on their stomach, or who have a neurodisability, something going wrong up here, are all more at risk of developing gastroesophageal reflux disease. And those babies will need to be seen by a GP for appropriate treatment. Okay, I definitely need to revisit these slides. I think I've put the same thing a few times. It was just obviously very important to me. I'm wondering whether I've maybe got an old copy of the presentation up here. I'll change them all before I put them online so you've got the right ones. So this slide talks about how human history having changed. So this is our new norm instead of this. And also it talks about how allergy can have reflux as a symptom. So reflux, milk coming up, can be the stomach saying, this is what I don't want in my stomach. And even though infant formula is perfectly appropriate for babies, babies can have an allergy to something in it. Even though breast milk is perfectly appropriate for babies, babies can have an allergy to something transmitted in the breast milk that the mother is eating. So we do have to consider those. Asthmatic children, more likely to be refluxy. It's a correlation though, not a causation, which means that one doesn't make the other happen, but both can happen in the same babies because of things like allergies. Okay, what makes it worse? Dooba-dooba-doob. Smoking, environmental hazard, bad for many reasons, but in the refluxy baby, those extra allergens going into the system seem to make the milk come back out again. Positioning, so that's not great for babies. That is also not great for babies. So who remembers when, I know Lisa and I will, the time when we had infant travel systems and the height of fashionability was to have a car seat that clicked into the pram. Yeah. And so the baby was going out for the day, it would go into the car seat, into the car seat would then click into the pram, so you didn't have to wake the baby, they'd go round the zoo for the day, in the car seat, in the pram, click back into the car. If babies are out and about, they should either be here or there. In the car seat or bouncers or things like this, the maximum we want is 20 minutes, ideally. Obviously, sometimes parents have to travel for longer than 20 minutes, right? So we're not saying they should not go more than 20 minutes from their home. If a baby's in a car seat for a long journey, we're going to get them out at least every 2 hours. But with young babies, we'd want to limit longer journeys and aim for baby to be no more than 20 minutes in this position. But, you know, don't scare parents over it. You're not saying they can't go and visit their mother because baby needs to come out. But we're trying to make sure that parents aren't then bringing the car seat in and leaving baby in the car seat like this. So car seats for travel, appropriate. Car seats for sleeping, car seats for being in the house, car seats for going around town, not appropriate. Same thing for baby bouncers. They're lovely, great for pooping. If you've got a constipated baby, put it in a baby bouncer, really helps. Shouldn't be sleeping in them, and again 20 minutes is a limit because they're not flat and they're not upright on a parent. So those can both make reflux worse. Obvious things like their clothing is too tight, lying down straight after a feed or overfeeding. I talk a lot about breastfeeding and mums can eat what they want, and that's absolutely true. When, or whoever's got kids in the background, can we just pop on mute? Thank you. When, however, a baby is showing some signs of distress and discomfort, we then do want to look at that mum's diet to see if there's anything that could be causing it. So what I really don't like is people who are saying breastfeeding mums cannot eat, cannot drink alcohol, cannot eat foods that are supposed to be gassy, which there's no proof of, like cauliflower, cannot drink a cup of coffee. We should not be saying that to breastfeeding mums. Breastfeeding mums should not be changing their diet because they're breastfeeding. But they may need to make a dietary change if the baby is showing some symptoms of being uncomfortable. And too much caffeine in a diet can make baby uncomfortable. If a baby has a cow's milk protein allergy, yes, mum will, if she wants to continue breastfeeding, need to go on a restrictive diet. But it should be a result of seeing changes in the baby and then monitored to make sure if it was those changes. It shouldn't be what I see a lot, you're breastfeeding, don't eat dairy, because that's not helping mums to breastfeed. We know maybe 5 to 7% of the population will have a cow's milk protein allergy as an infant. Is it fair on 100 mums to make them not have dairy because 5 of them, their infants might show an intolerance, when we know the benefits of breastfeeding? So what we're going to do is say, eat what you want unless it seems to be having an impact on your baby. And then we're going to look at what we can do to support you. Tongue tie can make reflux worse because that latch isn't very good. If the latch is not very good, there's air going down. There's air going down into the stomach, it needs to come back up. And when the air comes back up, it can bring milk up with it. Cow's milk protein allergy we'll look at in a moment, and a fast letdown reflex. So if mum's breastfeeding and she's one of those mums that squirts a lot initially, and the baby's like, lots of milk, they will often be taking in a lot of air at that point as well. So that again could be a reason why we've got a refluxy baby. So that mum might need to just do a little bit of hand expressing first before putting baby on, and then put baby on in a laid back position so that they can come off and on at their will to try and help to manage that situation. So things you'll be doing to help is to reassure mums that carrying their baby and frequent feeding are good things for this refluxy baby. If it's a breastfeeding issue, you're going to get trained support, and we're going to work on that winding of the baby. I'm going to make sure that they are either on their parent after a feed or upright after a feed before being laid down. Okie dokie. Right, who was asking about the sleep? This is where we come to saying safe sleep guidance is baby on a flat surface, and it's only if the doctor recommends that you will raise one end of the crib. And we're not going to use pillows, we would only raise the whole crib. And we're still going to make sure with that, we're going to have baby right feet to foot at the foot of the cot, and we're going to be even more careful that there is nothing over their face. And then the elimination diet for the mum is if we think there is a cow's milk protein allergy, which we're going to do next of all. But when it is severe and we've gone to the doctors, or when it has more of those symptoms that we discussed that might be gastroesophageal reflux disease, the doctors may well come in with some medication. They shouldn't do this until feeding has been addressed, be that paced feeding techniques or a breastfeeding assessment. That should be number 1. Number 2 should be positioning, making sure we're giving baby enough upright time after a feed. If those 2 haven't worked, then the doctors should go to medication if that's appropriate. So these are things to be aware of that your clients might be given by the doctor. It's not things for you to suggest, it's things that doctors would suggest. So Gaviscon and Carabel. Gaviscon you might have heard of for reflux for adults as well. When it goes in, it thickens what is in the stomach. So it helps it to stay in the stomach by binding it together. Imagine adding corn flour to your gravy. It's doing that. And that's called an alginate. That's the first thing they would try and do. If that didn't work, they might suggest a specialist milk. And as we learned in the second session on infant feeding, milks need to be prepared at 70 degrees or more to kill the bacteria in the formula milk. These specialist milks for reflux need to be made at a lower temperature, because if they're made at a higher temperature, they basically turn into concrete and the baby can't eat them. So you've got a real mix there. Is it right for the baby because it's clumping together the milk, it's making it thicker, so it's going to stay down? But also there's then an increased risk of gastroenteritis. So you've got to be even more careful with your hand hygiene. These milks should not be made up in advance. They should be made up absolutely to order and certainly finished within that hour, because there is more risk of there being bacteria in that milk. If those two approaches haven't helped, you may have something like omeprazole or ranitidine prescribed. And that actually looks at the acid in the stomach. They should have one, not the other, generally not together. And then there are some other medications, just so you know, that they used to be used. So parents might say, oh, should we try this? Or do you think I should ask my baby, my doctor for domperidone or metoclopramide? Because maybe they've had it with their 7 or 8-year-old child and it worked for them. They are no longer recommended in the UK. That may be different abroad, I'm not sure. When we've got these unwell babies with reflux, we find that about 25% of them do have a cow's milk allergy, cow's milk protein allergy. So when you've got a baby who's having this type of treatment, who's showing these additional symptoms, we're going to think of about a quarter of them may have an allergic reason for it. We're going to look now at what those allergies might look like. So if you want a loo break, now is a good time. I'm just going to have a glass of water. Notice a couple of people go, so we're just going to have two minutes, I think. Just have a moment and come back. And a lot of talking today. Be pleased to know there's no videos this week. Now you've done your videos. Next week homework is going to be a quiz on illnesses. So if you haven't finished your videos, you've only got those 3 to finish. Just wait for everybody to come back. How's everybody doing with the course? Anything that's been particularly difficult or anything you want question?
Me videos.
Yeah. You're going to get them done when you're ready. Yeah, as long as it's before your
Because I've
assessment.
been so busy, so.
It's great to have them through the course, but as long as you get them in before your assessment, that will be fine.
All right.
And we'll talk about the assessment on next Thursday.
Okay.
You have a good time to do that. So I will only mark whether you've passed or not when all of those things are in place, the videos and the written assessment. So
Okay.
don't worry. Right, is that everybody back? Yes, I think so. Okay. So going back onto this cow's milk protein allergy, who has cared for a baby with a diagnosis of cow's milk protein allergy before? Anyone?
Yes, I looked after a little boy who had a cow's milk allergy.
Okay. What was the management of him for? What was happening with him in terms of helping him?
So bless him, he had eczema and he had a cow's milk allergy.
Was this
She
a
knows-
baby or an older child?
This is a baby, so she noticed from 5 weeks rashes and really like just uncomfortable crying. And then when he was 5 months, so he had been put on a formula. I can't remember the name of it. It still had a trace of it. Yeah, yeah. What was it?
I said Nutriprem.
So he tried that one, but they still had the trace, and so
Yeah.
he was eventually he had the prick test, we went to an allergist and a dermatologist. He had the prick test, he had a blood test, and it came out he was allergic to cow's milk, so he was then on Neocate.
Oh, which is horrible stuff.
It smells like chlorine.
Neocate is horrible.
I mean, he was such an easy baby that he made a face for one gulp, and then
bless
yeah,
him.
I mean, he did the blood test. They took 4 test tubes without any numbing cream because he was obviously under 6 months and they can't do it. And he was fine. He didn't cry on nothing.
Bless his little socks.
I know. The mum was really, really like crying because she thought, like, she hyped up that he was going to be really, really set, like crying during it. But he was just so happy that the doctors were like, I can't believe it. But yeah, so he had a really bad eczema as well. We had a massive routine with that.
Which is all linked together, as we'll see in this part of the module. So 3 to 7% of babies, we think, will have a cow's milk protein allergy. And strong genetic component means that if mum or dad or close aunties and uncles, grandparents have had this, then you may well find the baby is much more at risk of having this as well. So be aware of your family histories. Exposure can occur within the womb. So if mum has a lot of dairy during pregnancy, it will pass through the umbilical cord like everything does. So it can actually sensitize a baby in the womb. But babies can also become sensitized after the birth when they first go onto breast milk, formula milk. Breastfed babies are going to be exposed to a much, much, much lower amount of cow's milk protein allergy through the breast milk than directly from formula. So even if mum's having, you know, cereal, milk, coffee, tea, milk, cheese, milk, she will be passing that cow's milk protein through her breast milk, but nothing like the amounts as if you give the milk fundamentally straight to the baby, the cow's milk or goat's milk formula. So breastfeeding is a safer option for at-risk infants. So if we think that we know that dad has a dairy allergy but mum doesn't, considering breastfeeding for that family will be even more important because it might be able to stop or at least lessen the amount of proteins going through to that baby and lessen the reactions. There are 2 types of allergy, and this is not just for cow's milk protein, this is for all allergies. IgE and non-IgE. IgE are those fast reaction allergies. So who has a friend or a child they've cared for with a peanut allergy that was one of those, if they have a peanut, they start to swell immediately? Yeah. That's an IgE allergy. So it's something that the exposure and then the symptoms come very, very fast within minutes. And those symptoms are really quite obvious in a baby once you know what to look for. So eczema, I mentioned this little baby had. Rashes in general, particularly low around here. Diarrhea, itchiness, swelling here. Persistent colic, this is the really unhappy baby most of the time, whatever you do. You could be baby wearing skin to skin this baby 24 hours a day and they're still super unhappy. Wheezing, a precursor for asthma, reflux and vomiting, sneezing, all of these things together are saying, yeah, we have probably quite a significant allergy. And like Leanne has explained, it can then be diagnosed with a skin prick test or a blood test. And once it's diagnosed, we'll look at what the treatments are. But fundamentally for a breastfed baby, the mum would have to go on a dairy-free diet. And there is lots of hidden dairy and stuff. So that's a hard gig. It's not just milk and cheese. It's like biscuits that have milk in them, all sorts. If it's a formula-fed baby, it is going to be a specialist formula. And there are certain formulas we'll go through. It's not just straight to Neocate, which is absolutely horrible. There's a ladder of things to go through to see how allergic is this baby, what can they tolerate. If you're suspecting cow's milk protein allergy, you are not going to go to a goat's milk though, because cow's milk and goat's milk protein allergy are generally found together. Remember that thing about the goat's milk not being more easily digested, not closer to breast milk? It's also not an alternative for a cow's milk protein allergy baby. and they're mostly allergic to, or many of them can be allergic to soya as well. So to be aware of. But it isn't the only type of allergy. Non-IgE is where symptoms build up over time. And the really difficult thing is that this cannot be tested for. It cannot be tested for. So if Leanne's little boy had non-IgE cow's milk protein allergy, that blood test would have come back negative. The negative blood test does not mean they don't have cow's milk protein allergy. It means they don't have IgE mediated cow's milk protein allergy. So these are the things you're looking for in a baby. Again, the colic and the reflux going up to that GORD, that gastroesophageal reflux disease. So they've got some other things going on. It's not just bringing up milk and being happy, some other stuff going on. Poor growth. This baby seems to be taking in enough, but they're not moving up on the scales. A pale skin or a pallor to their skin. Blood or mucus in their poo. Obviously, blood in the poo, you always are going to get investigated by a health professional. Can be that something's going on in the gut there. Mucus in the poo is a really good sign that this is a cow's milk protein allergy, should be considered. Constipated babies, and constipation can be just a result of infant formula, but let's put it together. We've got a few of these signs together. If so, we're going to think about cow's milk protein allergy. And frequent loose stools in a formula fed infant. We might call that diarrhea, but it's kind of happening over a longer period of time. It's not just an episode. So these might be symptoms of a cow's milk protein allergy that cannot be tested for. The only way that the GP is going to be able to support this baby is to try this elimination diet for the breastfed mum or a different formula. But be aware that just because they've had a skin prick test come back negative, it doesn't mean they haven't got the allergy. But if you look at those two symptom lists, they are very different types of symptoms, aren't they? So it should have been giving you a bit of a heads up of what you should be looking for and what you're expecting from your GP. Okay, we're going on to lactose intolerance. So before we go on to that, I'm just going to go over the milks. Or have I gone over the milks? Hang on, let me see what. No, I haven't. Right. So with the milks, the Neocate is the most difficult for a baby to take because it tastes vile. Sometimes people add vanilla to it to even make it palatable. Before then, there is a ladder of milks that have different changes to them that might help the cow's milk protein baby. So the proteins are broken down more and more, and the milks get more and more expensive as you go down this route. So be aware that there is a cost implication, but these milks shouldn't be taken just because you think the baby might have an allergy. This should always be in conjunction with working with your health visitor or your GP. You as a maternity nurse should never say, I think they've got a cow's milk protein allergy, let's try a special milk. That is outside of your remit. You must go through the GP route to support with this. Okay? Right. Yeah. So, lactose intolerance. Many people get very confused between cow's milk protein allergy and lactose intolerance because both of them seem to be to do with dairy. So we can't just say it's a dairy allergy. We need to be very specific about what is being allergic, the cow's milk protein or lactose. Lactose is present in breast milk and in cow's milk and in goat's milk. And you can't take that lactose out of breast milk. The mum can be completely dairy free, but her milk will still have lactose in it because that's a component of mammal's milk. But fortunately, a primary lactose intolerance, that congenital lactose intolerance, is extremely rare. So a baby born with a lactose intolerance, i.e. it cannot have its own mother's milk, is, as you would expect from Darwin, very unlikely, because we just wouldn't have survived as a species if most of us couldn't have our own mother's milk. And the babies who do have this primary lactose intolerance, the one that is present there from before birth, are going to be incredibly sick. They're probably not even going to get to you because mum will have not come out of hospital, or mum, if she had a home birth, will be going back into hospital very quickly. So it's likely to be in those very first few days of life before you've even started your work. and they're going to be super ill, and they're going to have hospital treatment for this, and they're going to be on a highly specialized milk. So it'll be completely managed by the pediatricians. You just do what they say. But many babies will over time develop a secondary lactose intolerance, and many of us do. This is something that is transient. It means something that's not there for life. It comes and it goes. Often this happens after a period of illness. So when the baby's ill, there's stuff happening in here that they're not happy with, the little villi, the little sort of hairs in the gut get a bit attacked by what's happening and by the illness. That process means that they find it more difficult to deal with the lactose in the milk. And that can make the baby show some symptoms of being uncomfortable. But if these villi are given time to heal, then everything will go back to normal. So secondary lactose intolerance is not something that is lifelong. It's something that comes and it can go. And just like we talked about before, the lactose in the milk needs to be processed by an enzyme called lactase. So if there's an issue here, then that co-leaf that has lactase in it might give some help, because it will help to digest the lactose. And when the lactose can't be digested easily, the body reacts by making it move quickly through the system. Okay? And this process happens in the stomach, not in the stomach, in the digestive system, in the gut. Okay? If there's a problem in the stomach, like the cow's milk protein allergy, the milk will generally come out this way. If there is a problem lower down when it's being digested, which is what will happen with lactose, that it's then not being digested, the problem comes out that way. Yeah. So if you've got a baby being sick, you're not looking at lactose intolerance, because the issue that the milk's passed through the stomach by then, it can't come back up then. It's further down the system. What you might see though is poops coming out that are green or frothy. And that's showing that there's a problem here in the gut. The gut can't deal with the lactose. If it can't deal with it, what does it do? It gets rid of it as quick as it can. That's how our body deals with all kinds of poisons and problems. It tries to get it out. If the problem's in the stomach, we sick it up. If the problem's in the digestive tract, we poop it out. So green is because when it enters this system, it has some biles attached, and they're kind of a green colour. And generally, the time it takes to move through here, those would be absorbed into the blood system. So the poop then comes out yellow or brown. When there's a problem and the gut is moving that poop through quicker than expected, then it comes out green because those biles are still attached. They haven't actually been reabsorbed. That's why there's green poop. The frothy is because they literally poop it out at speed and it hits the nappy. So do you know if you turn the kitchen tap on straight to fast, it goes whoosh, hits the bottom of the sink and it gets all bubbles at the bottom of the sink. That's pretty much what's happening with the poop here. So because of that, you might get some bum burn, you might get some real red irritation around the anus or the perineum. You're going to have an unhappy baby probably, and those nappies are going to be a key to show you that something is happening that they're not happy with. So diarrhea, green, frothy. If you're breastfeeding, you cannot alter the lactose in your milk, and going to a formula lactose reduced milk is less healthy for the baby. So what you're going to do is to help the baby, help the breastfeeding management to make sure that the baby is getting milk at an appropriate rate. So if there's oversupply, if milk's coming out very fast, or if, you know, when we talked about the composition of milk, towards the end of the feed, the baby has to work harder to get the fat down the ducts and out. The fat is what slows down the milk's passage through the digestive system. So if baby's only getting that start of the milk from each breast, it's not getting too much fat content, it's going to be coming out green. So we'll get some breastfeeding management in there from a qualified supporter to help make sure that this baby's having effective duration of feeds, they're getting to the fattier part of the milk and helping their position. If a baby is formula fed, then they may, by a GP, be offered some low lactose formula. There's no such thing as a no lactose formula, but there are lower lactose, but they're special medicational milks. So the GP should be assessing that. And if they do, what's really important to help the parents is to make sure they know that that baby should not be on that milk until they're 1 year old. They should be on it for a few weeks, which give those villi, the little stomach hairs, time to recover. And then the parents should try transitioning back to normal infant milk. You get a lot of babies who have this diagnosis and they're then on this special infant milk for life, as it will, for, you know, until they're on to cow's milk. That is not needed. They should be intervals tried back on normal infant milk, first stage infant milk, to see if everything's healed. That's actually the same with a cow's milk protein allergy. It can get better over time. So over time, parents take what's called a milk ladder approach, and they are asked to reintroduce milk in different forms to see what their baby can tolerate. So first of all, it's kind of introduced in a baked form. So literally you're changing the composition of the milk by cooking it. This is for over 6 month olds. Or in infants, you're changing the type of milk from neocate, where it's fully hydrolyzed, to a partially hydrolyzed milk. So you're seeing, where can this baby tolerate milk protein now? And babies will go up that milk ladder, and children will go up that milk ladder to see what can they tolerate and how much. And when they start to show symptoms, we kind of move back down the stage so that they're symptom free, stay there for a bit, and then move forward later in childhood. And often these things will change throughout childhood, but that will all be managed by a dietitian. Okay, that was a lot of talking. Back to the activity. Remember, we looked at this at the beginning of the session. Let's have another look at the same symptoms as we did before, and let's try and reclassify them into colic, reflux, both, or allergies. Who wants to pick a symptom and say that they think it goes under a certain column? Let's try and everybody do one before we then have someone repeating.
I'd say Archie's back is both.
Okay. Could be colicky or could be refluxy. Agreement, everybody?
Yeah.
Yeah. Okay, someone else?
Wendy is reflux.
Colic?
Knees up colic? Okay, everybody agree?
Yeah,
No.
No?
brings me.
What do you think knees up would be?
Yeah, it is. It is colic.
It is colic. That's colic.
It is colic.
Yeah, good. Okay, someone else?
Crying reflux.
Okay, crying. Babies do cry with reflux. Is that the only thing they're crying with?
Both.
Oh, both.
That's both.
Both.
It can be both. It's more likely to be the
Colic.
Colic.
So
Okay.
reflux per se is not involved with crying. Reflux, if it's GORD, if it's gastroesophageal reflux disease, then they may be crying through that discomfort. But fundamentally, reflux itself wouldn't cause crying, but that is a symptom of colic.
Hiccups, reflux.
Good, good. Hiccups, reflux.
Yeah,
Or if we speak to mum, completely normal for her baby in the womb.
in the womb, yeah.
Yeah, but we're looking at reflux for that one.
Mm.
Someone else hasn't spoken?
Brings up milk reflux.
Brings up milk reflux.
Reflux.
Yep, that's literally the definition. Reflux is not an illness. Reflux is the word we use to mean brings up milk.
Milk. Okay.
Vomiting, reflux.
Exactly same thing.
Yeah.
Eczema.
Eczema, Leanne, I can hear Leanne, and I know she had a little one with it. So allergy, yeah.
Windy colic?
Windy, colic, yeah.
Colic, yeah.
Anything else? for
Diarrhea?
windy?
Doesn't want to be put down.
Diarrhea, where does
Allergies.
diarrhea go?
Allergy?
Allergies.
We'll be looking at allergies. Constipation.
Allergies. Allergies maybe.
Can be allergies, can be reflux, can also, if the poop's not moving, cause colic. So going to pop it in both.
Both.
Because
Okay.
it could be making their stomachs still feel very tight. Red
That
rashes,
Allergies.
Allergies.
allergies, doesn't want to be put down.
both.
Both. Oh,
Both.
Yeah, often
Yeah.
we would suggest it was colic, but actually the refluxy
Well-
baby is going to be very uncomfortable like that, so
Mm.
it might be much happier like this.
Mhm.
Well done. Okie dokie. Right. Going to have a little look at jaundice. Do you remember Lisa Marie speaking about jaundice though in our first? I think it was our first video, wasn't it?
Yeah.
So
She
she
was
talked
in a
about. Yes, she was in a forest. She has 2 kids. Frankly, she just needed to get out of the house. So, as she said in the video, completely normal for many babies. So, around 60% of babies will develop some jaundice. Interesting, fun science. If most babies do something, we want to think why that is normal. And recently, there's been some investigation to put bilirubin, which is what causes jaundice, on Petri dishes. You remember from science, you put some bacteria on a gel and you saw what grew. Bilirubin that causes jaundice also seems to have some protection against sepsis, and sepsis kills babies. So there is some new science thinking that actually a build-up of bilirubin in the system can potentially be protective against sepsis. We're not sure. This is new science, but there is currently a theory that some build-up of jaundice is normal because it protects the baby against infection. But it's really interesting when we look at, what babies do, not to just pathologize it, not to just say this is a bad, I'm still holding this damn baby, to not just say, oh, it's a bad thing. And jaundice, as well, can be very dangerous for a baby. But actually, if it's low levels are happening to many babies, is there a reason why? And that may be the reason why. And hopefully in the next 5 to 10 years, we'll find out more about that. More common in premature babies. So that makes kind of a bit of sense, doesn't it? That premature babies are more at risk of illness. More of them have the thing that might possibly protect them from some of these infections. It's usually harmless, and it causes the skin to turn yellowish and causes the whites of the eyes to turn yellowish. So if you have a very dark-skinned baby where it's difficult to judge whether the skin is yellowing, let's look in the whites of those eyes. Also look on the palms of the hands and the feet to see if there's some yellowing. But jaundice normally travels down the body like this. So for your babies, you might start to notice the yellowing here, then you're going to notice it in the eyes. So look here before you look at the tummy or the legs if you're looking for jaundice. So bilirubin is a substance that can build up in the blood, and what gets bilirubin out is pooping it out. So if we want babies to poop out bilirubin, what do we need to be putting in them?
Milk.
Yeah, so fundamentally the best cure for jaundice is to get more milk into the baby, and especially breast milk, because breast milk is a laxative. It helps the baby poop it out. However, if jaundice develops in the first 24 hours of life, that is a huge infection marker, and that baby will, if they're not already, need to be hospitalized. So again, you're unlikely to see this because it tends to be in those first few hours postpartum after birth, and the baby will be tested for the whole meningitis, sepsis, all of those sort of things. So it's a serious thing in the first 24 hours. Other signs, if you're not quite seeing it, the face or the eyes, you're going to check the wee, and you should have newborns weeing like water. If it's coloured, then the darker it is, the more you're going to be concerned. It's the opposite with poop. New poop should be dark. If it's lighter and pale, that's when you're going to be worried. And the other thing about jaundice is it makes for very, very tired babies. Do tired babies want to feed?
No.
Nope. So you get a horrible vicious cycle of my baby's getting a bit jaundicey, so I should feed them. They don't want to feed, they don't want to wake up. So they're not moving milk through their system. So the bilirubin is building up. The bilirubin is making them tired. I should feed them. They don't want to feed. And that circle goes on. So although generally we're going to try to feed a baby responsively, i.e. looking for its feeding cues, if a baby is starting to show signs of jaundice, we are going to override those feeding cues by trying to feed that baby every 2 to 3 hours, or as according to what the midwives have told us. And we might need to be waking that baby to feed, really going for frequent feeding. If they'll only take half an ounce now, we'll feed them again and make up a new bottle, half an ounce in half an hour. Because at this point, we want to be getting as much into the baby as possible, because that's what's going to get rid of the bilirubin. It's not an option at this point just to let the baby go, oh, he or she is fine, we'll try again in 4 hours. Because that's just going to build up the jaundice, and you're going to have a tireder baby that's unable to get rid of the bilirubin, more likely to be hospitalised. So, treatment at home is frequent feeding. Sunshine used to be thought of as a treatment for jaundice. We used to say, oh, the baby's a bit yellow, let's get outside. It isn't a treatment for jaundice anymore. So we want to keep babies out of direct sunlight, full stop, even if they are a bit yellowy, okay?
Mm-hmm.
It won't do your babies any harm to generally go out in the pram or to sit in a window, but we're not going to use that as a treatment for jaundice. We're going to focus on the frequent feeding. However, if they get high levels of bilirubin, and the midwives will check that, generally they have like a little sort of, you know, the new temperature checks that just sort of look at your forehead in infrared. It's a bit like that. They put a thing here and it checks the bilirubin level. If that is concerning, they will suggest a transfer back into hospital, and mostly they're put on what we call the blue box or the Billy box, which is like a sunbed, basically, like a baby sunbed. They'll have little baby sunglasses. Sometimes it's just the bottom of them that lights up blue. If it's more severe, they'll have it top and bottom coming down, and baby will be in there just in a nappy, and baby will stay in that Billy box unless they are feeding. And the maternity staff there will be encouraging very frequent feeding, but if not, they're not then going to be skinning, they're going to be back in that Billy box. Because they're a very tired, lethargic baby, because they're jaundiced, they're not going to be crying. They're not going to be complaining about being on their backs, because these babies are really not very well at this point. Okay?
Mm.
So if you've got mums whose babies are going back in, you're going to be supporting the mum. You're obviously not going to be generally in the hospital with them. I mean, you certainly won't in COVID, but generally it would only be parents visiting. So you're going to see, you know, what else could you do to make these parents feel at home, feel supported? What is it else that you can do to help them to make sure that they're as best supported? Which may mean in this circumstance going a little bit outside your contract and going, I will go to get the shops for them. I will, you know, get the takeaway in or cook for them at their expense, of course. Just to make sure that they are well cared for, because they then have a baby in hospital. So we, you know, we're showing the compassion over the contract at that point. Right. The resource that Dr. Vicky mentioned, her orange book of childhood illnesses, will be sent out on this week's email, and it is fantastic. This is the most important page from it, because it's about the signs of illness, the things that we're going to really worry about. And Vicky did go through in her webinar, but it's so important we go through it again here so that no one can ever miss it. So the red risk is what we're looking at: the sleepy baby who is not at all waking up. You're not shaking them, but you're moving them, you're pinching them. Nothing is waking this baby. Very fast breathing. This is a baby we're worried about. Sucking in the muscles under the ribs. So baby's ribs here, if they've got a dip at this point and it's going in like this when they're breathing, yeah, this is a sign that something is not as it should be, and we need to get that baby pediatric checked. Moving the head when they're breathing, or any abnormal noises and grunting. Babies are really noisy, and that's one of the things that both new mums and maternity nurses have to learn, that babies are not silent. But if they are grunting as opposed to making little noises, we want to get that checked. The colour, so if they're looking bluey or grey, especially around the lips, or their skin is mottled, it's changing colour, this is not a good sign. We know that baby circulation isn't very good. So this bit might be warm and their hands and feet tend to be cold. That's normal. But if they are really cold, if you're touching them and going, oh gosh, then this is a sign that circulation is not working even well enough to keep them going. They need to go into A&E. If you've had more than 12 hours without a wee, that baby is dehydrated and you need to get it into A&E. And then temperatures. With the 0 to 3 months, 38 degrees or higher on your home thermometer, you are taking that baby in, or you're getting further medical advice. The hospital may then do a temperature check and find that it's not quite there, but we're not taking any, you know, we're not messing around here. 38 degrees, we are definitely going to be phoning 111 and getting some advice from them, which may well be to present at a hospital. If it's less than 36, then either something is seriously wrong with your thermometer, or again, the baby is very unwell, which is why this one says measured 3 times in 10 minutes, because that's quite unusual. So we're going to double, triple check it to make sure that this baby really is under temp, and then we're going to be taking them in. Babies get many rashes, and midwife Lisa Marie talked about that. But when you've got a rash, that when you press it with a glass or indeed a plastic baby bottle, and it doesn't blanch, it doesn't turn the skin clear or white, the rash you can still see is there, that is a concern. And something to be aware of, have you heard it? I think it's pronounced Kowalski syndrome, I think. A new post-COVID illness that seems to be happening in children, very, very rare still. That's coming up with a rash, but it is really difficult to see on different skin tones. Let me just grab you up the photo and I'll show you what I mean, because this is something that might be affecting more kids now because of COVID.
Yeah, I've seen that one. Rashes and then heart breathing.
Yes.
Then high temperature.
Let's grab this up. Boob. Okay, have I got a picture on this? No, I need a picture of no, that's just a picture of a boy. Because it's more likely to be happening at the moment, because COVID is prevalent, and it's more likely to happen to Black children because there is some link which we're not yet understanding, and it is more difficult to spot.
Yeah.
So it's really a concern for paediatricians that this might be going unrecognised. Why can't I find a photo of it? I saw them.
And it was all over the body, isn't it, Caroline?
It is all over the body, but it's very obvious on a white skin, but not so much on the children that they're seeing. Right, I cannot see it on my internet, so I'm going to find the picture later and I will send it to you on the email. Okay. It's one of those things that I'd never normally mention, but right now it is a genuine concern, and paediatricians across the country are seeing this happen, and you know we're worried about it. We're very worried about it. The non-blanching rash that this red is talking about, though, is the meningitis rash. So that's typically when you put the tumbler test on, you put a glass on the baby, that rash is still there, and that can be a sign of meningitis. So this, say, hasn't been updated for the most recent illnesses we're worried about. If your baby is having a fit or a seizure, you need to get some support. Febrile convulsions, which is infant fitting, is actually really common. But if this is the first time it is happening, that baby needs to be seen. We need to rule out epilepsy. Okay. So common newborn illnesses are talked about in the videos with the midwife and the doctor. So revisit those videos to learn more about them. And then the orange guide is a great one to actually print off and keep with you, because it's a lovely little guide to childhood illnesses, and I'm going to send that to you on the email. And we do strongly recommend that you undertake emergency paediatric first aid prior to starting work with families. It is not a requirement. Agencies will require you to have it, but private families do not require you to have it. The law doesn't say you have to have it, but clearly I don't need to explain why it is a good idea. So there are 6-hour and 12-hour paediatric first aid courses, and any agency will expect you to have that, and any parent who has anything about the wits about them will be asking you for that. And those should be updated every 3 years. Right, going to spend the last time, and I am on time today, haha, looking at our scenarios. Okay, so how many have we got today? 1, 2, 3. Right, I'm going to put you into groups and give you a scenario. Can some people just take a photograph? Because you remember it doesn't work with keeping the screen. So can you take a photograph and I'll tell you which scenario is going to be yours. Okay, right. People might need to put their mics back on. Sorry for the swapping and swapping, but
It's all right.
it worked very well.
I was like, the first break room was the easy one, and then the second one I was
They
like,
missed
oh, no.
you. They came up, they're like,
I
where's
was
she
like, oh,
gone?
yes, we've got the easy one. And then when I left, I was like, no.
Oh, well, we're going to start with you and Bella then on the first room, because Claudia, I think, is really not very well at all, so it's dropping out now
Yeah.
for the day. So we've got 5 minutes. We are not going to overrun because it's my birthday and I have a hot tub and a cake.
Oh, happy birthday!
So tell me about baby one. What are your thoughts about this baby?
So,
Allergy?
yeah, go on. Go on,
It's
Ben.
allergy.
What are your suggestions because of the allergy?
We said because the baby is taking the right amount of milk, but it's going from the 50th centile to the
down to
25th.
25th. Yeah.
And they've established that the baby has reflux, but it is still after half an hour, which a baby should be keeping the milk down. It's still vomiting and bringing up milk.
Yeah.
And obviously it's developing a rash around the mouth and the bottom.
And you're not doctors, but what would be
Yeah.
your best guess as to what type of allergy you might think they'd be looking at?
ACPMA.
Yeah, and a non-IgE mediated. It's not the one that is happening straight away. It is those symptoms over time that we are worrying about. Good stuff. Right. Who was scenario 2?
Me and Fiona.
Okay. Tell me about baby B. I really was imaginative with the namings, wasn't I?
So baby B. We said was we would think is most likely jaundice.
And what are your symptoms for jaundice that you're looking at there?
So the difficult to wake and the eyes showing yellow and the weight loss.
Yeah, and the fact they're breastfed means that we are more likely to be seeing jaundice.
Yeah.
So he's lost 10% of his weight by day 5. He's exclusively breastfed. It got off to a difficult start. How are we going to be helping this mum?
Well, so firstly, the ideal scenario would be for her to feed more frequently, but because the baby's difficult to wake, and I'm assuming that the yellowing wasn't showing at day 5, which means it's quite a serious case, and we'd be probably recommending that she goes to the hospital to get baby checked out.
Okay, something I wouldn't want to be missing here is we're listening to see that he's exclusively breastfed and it's got off to a difficult start and has not got much weight, so there's not much milk going in. If there's not much milk going in, we're wanting to be helping more milk to go in. So we want to be referring this baby on for an infant feeding assessment.
Okay.
We want to be helping this mum to get better breastfeeding going. Might be that this baby has a tongue tie that hasn't been assessed. So, it's not about mum not doing her best. Maybe there's a tongue tie here that is stopping baby from latching properly, and therefore there's not enough milk going in, and therefore it's exacerbating the jaundice. I think we'd probably not be turning up at A&E, but we would be calling the midwife for advice. Okay. But definitely we want some more breastfeeding support to help this baby, because the best way to help them is to get more milk in. Baby C group, tell me about baby C.
Baby C group, it's we think it's colic.
Okay.
Okay, so the baby has 8 weeks, so it's like 2 months. From 2 to 5 months, it can be colic. It's not going to get better. The baby cannot be settled in the crib, so
Are there any other things that you're worried about, or do you just get the, is there anything else underlying this from the symptoms you've been shown?
Yes,
Well,
evening, in the evenings for a few hours, the parents are
Oh
exhausted.
yes, so no, I agree it's colic. Sorry, my question wasn't clear. Are there any other things that are making you worried, underlying causes for the colic?
The parents are exhausted and worried.
Sally Ann?
okay. Maybe it's the feeding,
Mm-hmm.
or
It could be.
it could be.
There's nothing else here that's showing some worrying signs. So it might just be this is one of the many babies who in the evenings are more unsettled, but there is no worrying underlying reason. There's no allergy, there's no intolerance, there's nothing else underlying. This baby is just a bit unhappy. So the support we're going to be putting in here is primarily for the parents to be reassuring and supporting them with looking after this baby. Because there's nothing else showing any red flags here about actually the well-being of the infant. So this one might be one where that's just babies being babies, rather than there being anything underlying. Okay, so we're reaching the end on time. Final slide. So no more homework for this week because we've had our homework earlier in the week and we've got a few people catching up on their videos. Next week, I'd like to swap the sessions around. It was going to be session 7 on building your business and session 8 on the postpartum mother, but we have a wonderful maternity nurse joining us for some questions and answers with you, and she can do Thursdays better than Mondays. So is it okay if we just swap those around so that we can have her expertise in the right session?
Sure.
Yes.
Great stuff. So we'll be getting ready for postpartum bodies. There's going to be a video coming out to you from a postnatal fitness trainer on supporting women after birth, to those who want to start back with fitness, thinking about their pelvic floor health, that sort of thing. So that will be ready to watch either before or after the session. It'll be ready before, but it's not one that you absolutely need to see before we tackle that. And then the Thursday then will be the one that we do about building your business, talking to another maternity nurse about what it's like for her. So be prepared for the Thursday with any questions you've got about what it's like to be working in this job and you'd like to ask someone else. Okay, right, I'm going to get in a hot tub with some birthday cake.
Happy birthday!
Happy
Okay,
birthday.
I will see you on Monday. And I'm not going to forget it's Monday, not Thursday this time. I'm going to get my days right. Good stuff. Have a great weekend, guys, and I'll send that email out tomorrow.
Okay,
Happy weekend. Bye.
Bye everyone. Bye.
Bye-bye.
Bye. Good night.
Claudia.
Good night.